All right, good morning, everyone. This is Senate Health and Welfare on Wednesday, January 7th. This morning, we're going to take some time just to talk amongst ourselves about our interests and topical priorities, what we would like to see on the table and work with. We've got a lot of bills, and so we'll go through the bills in a couple of days. We'll take some time to sort out which ones rise to the surface for us, and then do what we can do. But I'm really interested in what your interests are. I know some of them. I don't know all of them. And I'm going to start with the old guard today. I guess you guys start with the young guard. Okay. That's it. I didn't think of. I think of experience. I'm sorry. I would be sensitive to that too. All right. Senator Cummings.
Okay, experience back. I don't know what the bills say, because I don't know that anyone had time to get a bill out as things were breaking in DC. I'm very concerned, since I've spent an awful lot of time in this building trying to get all the lodgers to have health insurance. I want to make sure that we do the least amount of harm possible. First, to people. And secondly, that we don't do so much harm to the health insurance market that it's going to end up in distress for years to come, depending on if people stay in it, if people leave it. I'm very concerned about if people either leave or don't have adequate insurance, that showing up at the emergency room will further stress our hospitals and their finances. It just got brought home to me the other day. I read an article, and apparently Jim Henson of the Muppets died from a strep throat.
He did. He had pneumonia as a result.
Yeah, lesions in his lung. 3 days.
Right. Yeah.
You know, that points out, can we mandate that schools test for strep throat like they used to?
Sure, write the bill. Get the bill.
When the Commissioner of Health comes in, ask him that question.
It's the insurance companies.
I know. I know. Exactly.
But if you don't have the money, you're more inclined to say it's just a sore throat, gargle with lemon and honey or something, and tough it out. Yeah. Sometimes that can be absolutely deadly. Okay. Thank you.
Senator Buick.
Oh, thank you, Chair Lyons. Oh boy, having spent most of my summer on the redistricting committee, it
Switch.
yeah.
No, it's okay. I mean, there's a lot of overlap in there.
There's a lot of overlap. It was brought home yet again that one of the biggest, if not the biggest, cost drivers that we are grappling with in the state is healthcare costs. So I am committed and excited to continue the work of bringing down the cost of healthcare in the state of Vermont. I think should be our number one priority. Creating bigger school districts is the answer, but bringing down the cost drivers, that is the answer to our problems. And in that vein, I think we should continue the work of, taking services and taking care out of hospitals and making it more accessible and more available to people, especially in rural parts of the state. I spent a big chunk of the summer driving on little roads all over the state, and it made me appreciate even more the challenges that folks in rural parts of the state are facing. whether it be access to education or access to healthcare. This is real, and we can't abandon those folks. So last year we passed the birthing center bill, which is excited. We worked really hard on the certificate of need thresholds. Those are important to, again, disseminating care around the state in a way that folks can access it. So all of that and keeping the quality high is critically important. I do have a bunch of bills that I would gladly share with all of you. I'm really excited about the one that really puts strong guardrails around AI therapy. We've heard over and over again about the dangers that folks are facing, especially young people, when they seek help from an AI bot when it comes to mental health. So I'm hoping that we can work on that. And then I have some other bills that I'll share with you, but priorities are around cost, access, and quality.
Cool.
Yeah.
Yeah, good. There's a lot resonating in this room. This is great. Okay. That's it. Just those little tiny.
Very easily achievable.
All right. So what are we gonna do third week?
I think this will keep us busy for a while.
Yeah, this will. Thank you. Thank you. I like the way you've taken your work this summer and moved it into what your observations of what's needed. It's great. Oh, great. All right. So I'm going to move over to this side of the table to save myself the cost. Senator Benson.
Yes, well, I would mimic many of the same things that Senator Bullock just mentioned. I mean, cost, access, as I mentioned yesterday, I'm concerned about some of our smaller hospitals or medical facilities. Access is critical for people, and if we lose those smaller ones and they have to travel long distances, that's not providing quality care. But at the same time, you're trying to balance cost. I also, as I mentioned to Chair Ryan this morning before we really started, I have gotten a couple of notes from constituents about S64. And so the chair said we would be discussing that at some point. So that's eye care. So
Yes,
Yeah.
just a few notes.
Yeah, just a few notes. So, but really, it's those essential pieces of cost balanced with quality and access.
Difficult because you want better quality, more access, typically costs go up. So this is a double-edged sword.
Yeah.
Live in the Northeast Kingdom. So the rural communities, and I'm already starting to hear. So I didn't know it was going to be on this committee yesterday. So now people are starting to talk, and of course we have North Country Hospital, and you also have an NVRH, and like Senator Benson said, it's they're critically important to Northeast Kingdom. And traveling long distances would be an issue. I also am really curious to hear your folks' perspective on. I keep hearing about all this money that's coming in from the federal government for rural hospitals. Does that sound right? And that there's going to be guardrails attached to that, I'm guessing. But
And we're going to hear about that on Friday.
okay,
Yeah, or next Wednesday. Scheduled, right? Yeah.
okay, and I don't know how that works. I'll be curious to see how it works. I also hear that UVM did really well. I think I read an article, or was it Latin? No. So
Wow,
I don't. It was
very expensive.
very expensive.
Fed. a lot of time. Why it was very expensive. It is one of the main drivers
Okay,
of our healthcare costs.
okay. And so I think I understand there's 14 hospitals in the state of Vermont.
Yeah.
And some of them are linked together. I guess like UVM must have some, Dartmouth has a few
Yeah.
in the state.
With a Scotney, yeah.
And it sounds like to me, Newport and NBRH are starting to collaborate more together,
Yeah.
which is
And
great.
with Gifford,
So those are, for me in my district, those are gonna be some of the things I'll be thinking about, listening to, trying to understand. I know it's very complicated. But I'll do, let's go again. So I'll be looking into the rural hospitals.
Your predecessor was a big supporter of your hospital.
Okay.
this is important here, say, because we get so used to it here, or at least I do. I mean, I went up and I talked with the rural hospitals sometime in the fall, some of our first snowstorm, of course, right? And they were talking about the relationship that they have and how it's saving dollars
Yeah.
and improving access. So it sounds to me like that's a good place for us to have some testimony.
Yeah.
We get some of those folks in because they are doing really good work.
I'm glad to hear.
So, yeah, so that we'll do that.
I'm also hearing that it's hard to attract good doctors,
Mhm.
especially in the rural areas. So I'm guessing I don't know if it's location or money or both.
Mhm. Yeah.
So I'm hearing issues surrounding that. I went with a primary care physician for 3 years. I couldn't get one, just couldn't get.
Right.
So if you can't get one, then what do?
You can't get one here.
You can't get one here either, yeah.
Well, primary care is an issue.
Yeah. And so I finally got one now. And then they offer you, maybe that's wrong, is it nurse practitioners versus a doctor?
Yeah, that's my primary care provider.
And how that works. Then I hear things about Blue Cross, Blue Shield, and so I'm hearing things. But my primary goal is just looking out for the rural communities.
Good. Well, and what happens in the rural parts of the state, because we're all rural, literally, everyone looks at Chittenden County as dense population, but the reality is we also have primary care access problems there as well. So it doesn't matter where you go in the state. There might be a shorter wait time.
Yeah. Dental is another issue.
Yeah, I'm glad you brought that up. Dental, still. Jenny, so.
Last year, we did for this, Michael Costa, they were going for a grant to train, do internships here.
The Maple Mountain.
Yeah,
Uh-huh.
it might, I believe I read they got their federal,
That I'm gonna, yeah, through the Rural Health Transformation Grant, they were written in. And so they will be funded in the first, as far as I know, in the first
it
process.
might be good to hear from you.
Right, so, so I will, let me share with you when I finish my thing and then I'll share with you
Okay,
what I'm hearing you say and we need, and that was one of them. And it dovetails with what you were saying, everybody was saying. Oh, you know what I like about this? We're all on the same page. We are. I mean, I think we see a problem, the problems that exist. Last year was really good at emphasizing solutions, some of the bigger solutions. Now we have to start to get down into the fundamental details. So, I mean, for me, as I have said before, it's primary care. We looked at hospitals. We're going to continue that, looking at hospital transformation. We're going to hear about the transformation process as early as tomorrow and the next day. And Jen will begin to help go through what's happened and what's going on. I do want to have the hospitals come in particular Michael Costa, because when I met with the group in the fall, what he presented was outstanding. You know, just some of the work the hospitals, the rural hospitals are doing is outstanding. And so I'll just say, preface, before I go to primary care, just one thing. One of the good things that our legislation has done is it has put everyone in the room together. So it isn't a single hospital making a decision about what needs to go and what needs to stay, but it's more of a collaborative process regionally. And that's what you were talking about. And you're talking about how can we regionalize? And that's what the administration is now talking about. Identifying our legislation, our laws have said, go identify the gaps. And then come back together and say, how are we going to work together to fill the gaps? So that's what was so refreshing to hear. Now, obviously, each hospital has its own financial sustainability problems, you know, and there's a lot of tension and competition going on. Nevertheless, there's also an understanding that if we don't do something, and that's us and it's them, world, if you don't do something, it's going to fall. So it's good to hear what you're saying, because I think it resonates pretty much with where we are. Primary care for me is absolutely critically important because it leads to prevention of all those chronic diseases and acute care needs that we see when people have to get to the hospital. And then, so I've said this before, you know, primary care, we need primary care docs. We put significant funds into loan repayment, and we'll continue to think about those workforce dollars needed to keep people in the state, to draw people in the state. It's for nurses, it's for docs, and all the way down to the LPNs. We still have an LPN program that's ongoing. There's money that's being expended for that. The federal dollars that we got from ARPA, we heard about that a little bit yesterday in approach. So there's a lot that we are doing, but we want to make sure it's ongoing and that we have an investment in the services that we need, everything from a primary care and mental health counselors to hospital-based services. So when I think of primary care, one of the things that I'm learning from the advisory committee that we put in place, we have a primary care advisory committee that is participating in the state transformation plan. And they're a very robust committee. And when I talked with the chair of that committee, I think she's shared to the doc, and she said, one of the best things that you can do is exactly what Senator Gulick said, and that is there are things that are happening in a hospital that could happen less expensively and closer to home with primary care. So we can't do that. I mean, we can't pick out those things and move, but what we can do is to have policies in place that help that discussion. So that's a piece of that primary care discussion. Probably and as we go through the bill, you know, we'll talk about other things. Obviously, this is important. Equal pay for equal work, affiliated versus independent docs, the whole issue around how do we pay people, what's the payment process look like? That's a lot of work. We need to think creatively about how we're going to do that to keep people in the Northeast Kingdom and then to attract them in and keep them at home. There's a huge differential between affiliated and independent. I'll just say salary-wise, it's huge. And so and the cost of living isn't that much different. So those are some of the things. So the workforce, the primary care, and then I'm interested in all the things that you guys have talked about. I think it's awesome, really, and including the AI therapy guidelines, wonderful guardrails. And then the recovery substance use disorder continues to be a huge problem. So, you know, needless to say, I think we're all interested in all of this. let's not overwhelm ourselves. Because it is, and it's complicated. We will, there are some very thoughtful bills that have come in, both from the administration, from the regulatory body, the Green Mountain Care Board, from us. We'll look at those bills and we'll try to take all of the things that we care about and see if there are pieces that can move from one bill to another and consolidate. Like, I don't know, there's a lot of redundant thinking. That's a good thing. That means that people are on the same page. And it's good. So I don't know where I am. I'm all over the place with stuff. So yeah.
Madam Chair, it's been a while for policy for me. So what, say we form a bill and we do some of the things we're talking about here today. How do we know what the cost of that policy change is?
So this is why we take testimony. We're gonna have to take testimony and listen. So you'll hear one thing from the hospital. If you do this, you're gonna destroy us. You'll hear the same thing from the insurance company. Then you're gonna hear the independent physician say the same thing. So then ultimately, we have to try to fit all of those things together and then listen to the Green Mountain Care Board and Department of Financial Regulation. And what do they say? Well, yeah, we can balance this, or we can help with that. And then finally, we come up with a decision and our joint fiscal office says, oh, this is way over the top, or yes, you're within this area. So it's not a simple process. And I think we're at a stage now where we've heard a lot about the financial sustainability of each of the groups.
Okay.
I think we won't make a really obtuse decision. I do. I think we'll be okay.
One thing we might want to check on. Our team mentioned the birthing centers. Did you
Yes.
see them?
You want that name?
Well, Gifford is our latest cost, that's it, Copland.
Yes,
Closest birthing center,
yes.
or closest hospital upstairs.
Hospital,
Yeah.
yes.
And, but the birthing center can't go there because they need a hospital with obstetrics for those rare cases where there's an issue. So the birthing center may end up in Waterbury, which is not that close to Copley, but is 10 minutes from my car. So if you're in an ambulance with a siren, it's a lot less than that from CVH and not much farther from UVM. So we set them up. And we just said, oh, well, yeah, they have to be near a hospital, but that somehow is causing some issues because if they're trying to replace a hospital birthing center and then that hospital doesn't have the facilities, they can't, I'm sure they can't get insurance to be there.
So you bring up a real good point, and we'll have folks in on that. We'll ask questions about that. We can do that as we're going through a discussion on transformation. One of the things that the Green Mountain Care Board is establishing criteria for closure, and it has been based on budget, but it's also based on proximity to like similar services. So we'll, yes, raise big.
Yeah. I was
And we'll
gonna
start
say,
with that.
I think what Senator Cummings is talking about here is regionalization, right? If we're
Yeah.
looking at a region
Yep.
and we have like a coherent plan for that region, then there won't be this sort of like haphazard,
Yeah.
closures and openings.
Yeah.
And they're all connected. You need a really good ambulance service, but you're inclined to have first time Barry Town took over Montpelier's one of the towns, they went to the wrong address.
Oh,
As they-
So that's a whole dispatching issue.
Yeah, right.
Oh, that's what
Dispatch.
Well, that's the
I
other
told
one.
you.
I got involved in all that stuff before.
We were gonna get overwhelmed.
It's been 10 years. I tried Sam buying a ladder truck over 30 years ago. We bought I think they're up to $3 million now,
Yeah.
ladder trucks.
Yeah.
Within
30 years
8
ago.
months.
Yeah.
I'm trying to think, was it 30 years ago? Yeah, at least 30 years ago, I tried to regionalize dispatch for police and fire in Chittenden County. And boy, was that a fun,
PSAPs and all
that was a fun time.
Yeah.
I participated in all of that.
You-
Went to the 911 system, and I
Yeah.
think the state dropped the ball when they didn't take it to the next step, which
Yeah.
is to actually set up the dispatch centers. So they did the call centers, but they did not take it to the next level, which is to have the actual dispatch centers. And I know personally, I dealt with that, having when the little dispatch center in Randolph closed. And then negotiate, we found our ability to go down to Hartford. And then we've been in 4 different places. We're now in Berry City, but it was difficult.
Yeah.
To find a service.
Yeah, and I think down your way, the Orange County Sheriff stopped doing dispatch and there were sections.
And what's left of the Orange County Sheriff.
Yeah.
Yeah,
I mean, we
Okay,
there
now.
were other issues going
This is
on.
not the Judiciary Committee.
But I would, if I could, Madam Chair, just go
Yes, sir.
back to a comment that Senator Cummings made, and that is, it would be great if the hospitals themselves would get together to do exactly what you're saying, as opposed to us dictating
Yeah.
where things come from, to say, hey, we've got this, how do we all work together? Where this hospital provides these services in the region here, so that they all basically survive, when we all provide that quality service to the constituents. But it's not us kind of saying, you do this and, because
So I would like to say thank you for that comment. And I think that the work that we did in here last year in particular, but the work that we've done on 167 and then Act 68 last year, Act 51. The work that we've done there has been a gradual transition to bringing folks together outside of this building and to have things happen, because there's no way that I do not want to tell a hospital that you should or should not close the children's beds. As you know, that's not my job. At the same token, Rutland made the decision independently and without the regional discussion to a large extent. So now we've gotten to a stage where folks understand well, we're responsible, but we're also responsible for engaging our community members to make it happen. You're right. Top down doesn't always work, but we also know that things have to happen. So there's a way we can get the crowbar out. Anyway. I had just a couple, one more. So you've identified the other thing, and that is the criteria for closures and access, and how do we build that in here? And you can have a really good policy that says you go do this, but it isn't going to work if the people who you're telling to do it are unwilling. That's part of the problem. And we try to work together as much as possible. My other concern that I have seen, as we've gone through all of this transformation work is, who's in charge of what? So Freeman Care Board, Agency of Human Services, Department of Financial Regulation. So at some point, I'm gonna bring folk, I think Jen will help us understand what each organization is responsible for, and then we can sort out what makes sense, given where we are, just by listening to folks. We're good. One more comment.
The frustration comes in Or 300, 60, 70 small towns.
Mhm.
We haven't done centralized dispatch for Barry, Montpelier, Washington County yet. 5 years of trying, and that's been 20 years of other trying. We're in a crisis with our hospitals. And it is very difficult for what was an independent, we make our own decisions, we are our towns or our region's hospital, to give up that power and control. But sometimes they need encouragement,
A loving nudge.
a loving, or a big stick and a nice carrot.
Big juicy carrot.
Or a
But
what,
it's, there's a point where we can't
a big, oh, the carrots and
wait,
sticks and carrots.
something bad will happen.
Question is, do you try to do a great big thing all at once or a little bit at a time? Exactly.
And-
Typically, a little bit at a time works better.
But we, in healthcare now, we have reached tipping point. And this doing away with the tax subsidies is,
Doing away with the tax subsidies is cruel.
is,
It is absolutely cruel.
I'm looking into with a family plan for costing $45,000 a year.
So,
And we reached the tipping point where single payer, I've told the candidates 17% surcharge on your income tax. We may reach the point where that's not the horrible number that it was the last 2 times the legislature looked at it.
that's why I mean, payment reform is so very important, and I'm having discussions with some of the chambers about how to do that. Keep your fingers close. So, oh, this has been really fun. Seriously, it's good. I love hearing your perspective, and I think we're all on the. We've got some very specific concerns. The birthing center is one. The hospital's another. We're gonna bring folks in on those things. And we have lots of bills that'll get us going on regionals and. We have with us this morning, Dr. Rick Hildebrandt, who is the new Commissioner of Health. And so Dr. Hildebrandt, why don't you come up? Sure. Good to see you again.
Yes, sir.
And you brought a team.
I did.
And what I'm gonna ask of you is, as we get started, we're gonna introduce ourselves first. Then have you introduce yourself, or give us a little bit of your background. And we're going to try to consider this your confirmation hearing as well as a report and update on some of the work that's going on,
Okay.
including recovery centers. And if that doesn't work out for committee members, we'll bring you back in.
Okay.
Again. But, so I'm gonna start over here.
Senator John Morley, Orleans. Nice to meet you.
John Benson, from Orange District.
Jenny Lyons, Chittenden Southeast.
Martine LaRocque with Burlington, Chittenden Central.
Incoming Washington District, right here.
Great to meet you.
Welcome.
So I do have some slides, which
You may want to introduce yourself for the record first.
absolutely, my name's Rick Hildebrandt, and I'm chair for the and again, the slides are light on content and just the visual thing there, but I really want to focus on the conversation more than anything else. I did want to give a little bit of my background. So as you may know, I'm a physician. I practice in the hospital in the inpatient unit and have done so for 13 years down in Rhode Island. When I started that, came there right after my residency training in Dartmouth. When I came to Rutland, a few things were immediately apparent to me. One was that there was a lot of folks that were making decisions in the hospital administration and others without any clinicians at the table. And it wasn't because they were excluded. It was because people weren't really raising their hands to say, hey, I would like to be part of this discussion. the physicians really wanted to do clinical work. So I started inviting myself to a number of meetings, which found me on the leadership track, which was not in my plan at all. And saw a series of promotions over the years.
Volunteer.
Yeah, exactly. Because of me, really. And found myself in a number of, medical director of the group and then into the executive leadership over time. But the other thing that was very clear was that I can't solve the problems of my patients in the four walls of the hospital. They're too big and they require more people than we have here. It's not just medications, therapeutics, nurses, and doctors, but it's coordination across the system. So I reached out to our community partners. We have a structure in Rutland that ultimately turned into something called Rutland Community Collaborative, where we have all our local area healthcare stakeholders meet once a month. We talk about issues, challenges, come up with plans about how to address them. And initially it was really focused on very tangible hospital things like readmission rates and ED visits and trying to work with those. We were very successful. We looked at some specific diseases. Although over time, it still wasn't really changing much. I mean, I'm still seeing repeat patients come in again and again and again. And even with the best coordination of care, it was the social drivers of health that really were driving a lot of these issues. Lack of financial resources, transportation, adequate food nutrition, access to healthcare, but all the same social drivers that we see across the state. And that led me to look at different boards and commissions around the community and around the state. I joined the local designated agencies board. At that time, I was in a role called Chief Medical Information Officer, which is this really interesting intersection between EMRs and physicians. Challenging work at times, but I have a bit of tech focus, so or bent. I joined Vitals board, which was really interesting. Had a great perspective around the state. I joined the board of medical practice and served as their chair for 4 years as sort of a regulator, which was also very, very interesting to me. But more and more, my interests lie outside of the hospital and in more of the systems that we practice in and work in. I was the COVID czar for COVID at our hospital. And when Mark had announced his retirement, I had thought to myself for a while, hey, if and when he decides to retire, I'll throw my hat in. And 6-8 months later, I found myself in the position. And it's really been great. The health department has really blown me away. I've learned a lot in my almost 3 months there. I've learned that I have a lot to learn. But what really struck me was the caliber of the individuals that work there are just amazing. And I don't know what I was expecting, but these are like the best of the best people that we have there. And it's really been quite nice to see that. Really caring people who work very hard with the needs. So the next slide this is our mission, our vision, and our values. And I put this up here, to remind us of what it is, but also the other reason that I felt I wanted to pursue this role was I felt a calling to do so. There's an attack on science and on public health around our nation right now. And this really spoke to me. And I felt like if I had the ability to do something, I ought to do something. And I was really driven by the mission of the Department of Health. Public health can be something that's challenging to define. When public health is doing its job, nothing bad is happening, right? And we use this schema of detect, connect, prevent, and respond as a way to think about public health. As a very tangible example, a number of weeks ago, we had an outbreak of pertussis, whooping cough in a Washington County school. So we detected that there was this thing going on. We responded by giving the school and community resources that they need, whether it was education or access to vaccination or whatever they needed to protect themselves and their families. And we alerted the area healthcare providers that, hey, this is going on, how to help prevent the spread. And that was, sort of a good example of what happens here, but it happens in infectious disease. It happens in so many other different ways that I was never aware of before taking on this role, whether it's in environmental health or chronic disease management. So many weather emergencies, either hot or cold. There's so many different ways that the health department will get involved in this sort of response when things happen to try and prevent it from spreading. This is our organizational structure, and I don't expect people to digest all this, but the health department consists of about 600 positions, and we have 12 district offices in each of our communities that help serve to connect with Vermonters and with the local area resources that are there. I oftentimes refer to this to remind myself of all the places we touch, all the people we touch. And to remind myself that we range in what we do from very, very concrete clinical services like the Office of the Chief Medical Examiner, some nursing home visits for new families, lab testing, to more community-based work like chronic disease prevention, health promotion, environmental health, looking at air quality, soil quality, food safety. And it's really nice to have experts in these fields because there is so much information to know that there's no way one person could, but we have experts in all these fields that are incredibly knowledgeable.
Highly educated,
Yes.
and experienced.
So one thing that I felt is very important for me to do in taking on this role is to preserve the trust in public health. We exited the pandemic with a very good reputation, and that was not true in every state. There's some state health departments that had a really tarnished reputation after the pandemic, and I credit the health department, I credit Dr. Levine for doing that. But there's a tap on public health right now, and it's my job, it's our job to make sure people see us as the solid authority to give accurate information to the public. And that's something that's very important to me. There's so much misinformation out right now. It's been challenging, to be fair, and our comms team has been working very hard to ensure that people have that knowledge, but that is a very important piece to me. The other piece, though, is it's not just about sort of central office communications. It's about those connections and communities. That's really how we have built and maintained that trust. People know other people in communities, in our district offices, with our healthcare providers, with patients, with school nurses, you name it. Those connections matter so much because when you have a personal connection with someone that works for the department of health or the state, it really helps build that trust. I suspect there will be more of this discussion in the coming year, as there has been just in the last week, but that is again a big focus. So speaking of immunizations a little bit, there's been a lot of false claims and falsehoods around immunizations in recent news. We just had a big announcement from HHS this week that dramatically changes the immunization schedule, which is a big concern of mine. And it does so based on, I can't find any medical knowledge to support the changes that are made, which is of significant concern. So we have a large group of stakeholders that has been working on this for a long time, since the first ACIP being minutes ago, including the Health Department, Department of Vermont Health Access, OPR, and Department of Financial Regulation, many, many more, to ensure that Vermonters have access to vaccines if they would like to continue having sex. And that information is available to both patients and to medical providers about what the recommendations are for vaccines. So that's been a big piece of work. We'll continue on that work all year long, I suspect. And you may see me in some new media around that particular topic. Another thing that has been a real focus of mine, and this is again, just in a few months, has come up a number of times, is around access. I know you guys were having a conversation just before I joined about healthcare access. I care about this not only as a provider and someone who has worked in the hospital for quite some time, but it's also a public health concern. If you don't have access to, as an example, maternity care across our state, that's a public health concern.
I just want to go back to the previous slide where you brought up the immunization bill that we have in committee, that the House also has in committee, and the House is going to take the bill up first. And I know that I think you're testifying in there yesterday.
Yeah.
I'm behind.
Okay.
But so, yes, and so that's a really important, I'm not sure that we heard the emphasis you placed on fast track.
Yeah.
And it's an important bill to have happen quickly.
Correct.
So we'll hear your testimony when you come in on that.
Yeah.
Thank you for the work you're doing.
Absolutely.
Madam Chair, can I get this to follow up to your comments, since I'm not up to speed on all the bills? Is the connection between what comes out of the Department of Health in terms of recommendations versus what the insurance companies are going to cover for folk, and if those two don't jive together, that creates obviously a hole in the system.
Yeah, so
Part of the bill.
that's part of the bill.
Part of the bill. And I agree with you entirely. The good news too is that people like Blue Cross Blue Shield, they see this as a money saving measure. I mean, vaccines prevent illnesses and very expensive hospitalizations. It's not a cost to them. They see this, this is something they want to support. So that's the good news. But yes, it's part of it. So again, back to access, obstetric care there's been lots of discussions around obstetric care. There was a discussion in Rutland about pediatric care. Transportation to services has been a real challenge. And there's much needed change in our EMS system to allow for regionalization efforts to occur. Current reimbursement structures for EMS do not support hospital transports. They don't. They support bringing people to ER, which is not always what we want. We may want them to treat someone in the field and then not bring to the ER, or treat someone in the field and send them to an alternative site, or give substance use disorder treatment. So we would like to help with all of those things to try and reduce the burden on our healthcare system. And EMS is a big part of that. Good question.
It's just funny, I deal with an ambulance service, and so I think you kind of got it here, you're talking about. I see again, regionalization coming into play here. Some of that, I even went way back and say, why doesn't the hospitals take over the ambulance departments? And because they work so closely with them, but I didn't get much traction. And then you hear about the Medicaid, the Medicare reimbursements, and all that stuff.
That's been a discussion, I'll tell you, in Rutland for a long time. And the reality is, ambulance services do better at emergency services than hospitals do in most cases, unless you're very, very big. We shouldn't be running a transportation service as a hospital. We should run a hospital. That being said, insurance services need more resources to do what we're asking them to do, which will save the system money, but they need to be able to, as an example, bill insurance for delivering care that doesn't report.
Well, it's so underfunded that now we're going to the communities that we serve and requesting funds in order to offer. So that's how bad, and certain regions are worse than others over that.
Correct.
Madam Chair, could I just follow up? Comment as my understanding is unless they transport, they do not get reimbursed. So your comment about treating on site is a whole different animal that would have to be addressed in the process.
Agreed. And that's something that I hope to do, because it can't be just state funded. That's not sustainable. It needs to be, we develop a system that allows the ambulance services to bill an insurer for providing medically necessary services that's going to save us all money.
Exactly.
Right.
That's what I was just going to say. It's certainly a lot cheaper if they were to administer care than bringing them to the ER and then having all those costs.
Right on track.
So we were talking about one time doing it countywide.
Yeah.
And, do the town, the county courts and things of that nature, so that everyone within that county needs to make that part of the county budget. I lost that one too.
You may win it sooner than.
Well, the thing I would say is I think that the EMS systems are ready for change now. There's been some resistance to change, and medicine in general, there's a team to change, just to be completely transparent. Okay, I've been working for decades. There's financial challenges, there's quality concerns. I think there's a readiness for change that hasn't been. So this might be a burning platform opportunity. Just anyway. The last item that around access that has been on my radar is around reproductive health. And we want to ensure we have access to these services despite any federal changes that come up. We did in our BAA touch on this briefly as they're concerned about some potential Title X changes. But it's part of our constitution and protected, and we want to ensure that we get access to services is really important for us. All right, and then the last focus area for me, and the part of the reason you're here, is substance use disorder, something that very clearly was something I was discussing and talking about and addressing from very early on. Substance use disorder is not a new problem. It's a continuing problem that has evolved over time. And I think Vermont has done a lot of excellent work in this space. And we're a leader in substance use disorder treatment in many ways. Our hub and spoke model has been very successful. More and more patients that I see on the inpatient unit, there's less of them that are actively using IV drugs and more of them that are in some form of recovery. Okay, now they may have had a relapse but many, many, many more are receiving active treatment and these treatment options available that were not there. However, the field is changing. We're seeing a change from opiate use disorder to stimulant use disorder, which is an entirely different bird, and polysubstance use. Within the stimulant field, cocaine is the number one drug we're seeing of abuse, but there's an slight increase in meth, which is something that's very, very concerning to me. Amphetamines are probably the worst drug abuse we've ever invented as humans. And my colleagues across the country who have patient populations with high meth use, it's scary, the stories that they tell me. These drugs can cause people to become violent. It's very hard to recover from. It takes years. It takes years for drug recovery in any instance, but it takes longer with meth. So with symptoms. So
So at some point, it would be good to have you folks come in and just talk about the different substances and what you're seeing from your colleagues across the country. And methamphetamine being one that's been on our radar for a while, but this I think would be good because it leads into some of the behavioral health issues that we see and how we deal with those in community services or in the judicial system. To do that.
yeah. And in the sort of treatment space, one place that, very clearly came up first is mental recovery housing. There's housing challenges across our entire system. I don't care what type of housing we have a shortage of it, right? But recovery housing has a real shortage within our system. It's something that we're working on increasing, as you'll hear more about in a little while. We also, I feel strongly, prevention is so important as well. We are increasing our work in prevention to try and decrease the amount of opiate abuse that we're seeing, not just helping folks who need treatment and recovery, but preventing its use to begin with, which is really challenging, but very, very important one. Okay. So this is a number of highlights in the substance use continuum. I will touch briefly on all these. The point I want to make here is there has been a lot of movement in a very short period of time in this space. And that's been really remarkable to me, how many things have happened just in the last, 6 to 8 months in this space. In terms of community-driven planning, so back a year ago, in December of 24, we published our statewide community informed needs assessment. Then in April, we published the Health Department's community informed strategic plan. October and November, we did a number of listening sessions in the 12 districts to find out what's the challenges people are dealing with. There are a lot of common themes, and housing and transportation being probably number 1 and 2. Okay. But that has really helped to identify gaps that we can come to address together. Improved access to help. So BT Helplink is now 24/7/365. We have phone, online chat, and Spanish language. And we have outreach workers engaging with people early and involved in transportation services, so they have access to treatment, recovery, and employment. Our crisis response has been strengthened. So our mobile crisis teams respond to both mental health and substance use disorder crises in communities. And we have integrated crisis beds in our virtual public immediate screening to reduce the pressure on our emergency department. So again, trying to help treat people in the community as opposed to all bringing them to the ER every single time we have it. Prevention work, as I had said, we have a multi-decade funding base, which has been $1 million. And in 26, we're going to be utilizing new funding from the Substance Misuse Prevention Special Fund, which is an additional $2 million in supporting 8 additional districts and supervisory units for building capacity in the space. There's a lot I can go into in the prevention work, but I'll leave it at that because this probably deserves its own deep dive.
Right, we'll be discussing this. I know that there is you and I have talked a lot about nicotine access in schools and prevention efforts there. So it would be helpful at some point to have that conversation, I think, with the whole committee. We were talking about it before you came in.
Yes.
And the levels of nicotine that kids are exposed to that's not measured,
Right.
not disclosed.
It's scary.
It is scary.
Right. the potency matters for all substances. I mean, you see that not just in nicotine, but in marijuana too. I mean, people are having huge medical problems because they've used marijuana for 30 years. But it's not the same thing nowadays. And people are ending in the hospital with either recurrent vomiting or psychiatric conditions. Expanded treatment options, a lot of movement in this space. So we opened, we have the work that Valley Vista to open some low intensity residential treatment services just recently. And we have a new hub that's opened in Bennington. I had a chance to visit it, which was great. It was a great facility. And then we're going to be implementing a number of CCBHCs to help expand access to not only substance use disorder and then co-occurring disease, which is really a huge need that was happening. We have, and then the last thing I'll just say is support for long-term recovery. So recovery coaching in our emergency departments and in our correctional facilities to allow for immediate access to these services, and certification of recovery centers and recovery are being implemented as well. So expanded recovery housing is, proposed. It's in alignment with our recovery housing assessment report that we recently released, and is sort of central to a lot of this work, and is really an important piece of the puzzle that we need for treatment of substance use. So here's our 3 key takeaways. I won't read them off the list. I do welcome any questions that you all have, and I look forward to talking more with you in the future.
Thank you. This is a really good overview. I think number 1 on your list that's so critical right now when we're seeing such changes at the federal level, and it does influence people when they try to sort out who's the expert, and the megaphone from Washington is much greater than the megaphone and the ability to communicate in this small state. But thank you for your work and for being here. Questions committee for the commission.
But it was a very thorough presentation.
Yes. Doesn't sound like you're going to have a lot of pushback in here.
I'm sure we'll have heated discussions, which is good. I love having discussions. That's always
We will. I know we will.
Some confirmation.
What is it? Do you have any specific questions to understand the role that this commissioner will play?
Okay.
Okay. So we have someone here, Emily Tudor, is it Tudor, sorry, here to talk about the recovery report that we got. And this is an important one for us. And I will say, I'm glad that you hit on prevention and recovery, prevention for opioids and substance use disorders. Because we do have a bill in here for recovery residences. I know we'll be hearing about the bill more specifically. This is really to set the groundwork with the report that's come to us. So I'm going to let you introduce yourself and then give us the update that they hold.
Good morning, everyone. My name is Emily Truder. I am the Health Department's Division Director for Substance Use Control. I've been with the department for about 32 years. It's my 30th year in substance use.
So you are our expert, and we
I've spent a lot of that in the financial and operational realm. A lot has happened via osmosis along the way. I am currently the Division Director and have been for about 2.5 years now. Thank you for having us this morning. I definitely want to thank and reiterate some of the things that our new commissioner had to say, especially in regards to our system at large. Substance use is currently one of the toughest public health things that we are currently facing in Vermont. Obviously, it's not one of several, but it certainly is a priority for at least the work that I do on a daily basis, and a lot of our wonderful community partners and systems that are out there. We have a lot of people working every day, working this moment, working to help people improve their lives and seek recovery. The landscape is constantly changing. You did hear the commissioner speak about stimulant use disorder. The changing of the drug supply and what is out there currently being used. I do need to take a moment to talk about alcohol. all the other substances that are out there are an issue and we need to focus on them. Polysubstance use is definitely part of the mix, but alcohol still is a bigger driver for health impacts than all the other ones combined. So I do just want to put that out there on the table this morning.
Thank you. And let me ask you a question about that. So frequently what we hear is, oh, these are the gateway drugs too, you know, opioids, so whatever. Where does alcohol fall in that hierarchy? Or is it just alcohol perpetually?
It's everywhere. I would say it can be a gateway, you know, as part of, it's obviously it's a legal substance, it's part of the mix, it's part of our society and our societal norms.
Yeah.
It is complicated across the board. It's an issue in every state. That's not unique to Vermont. It's health outcomes, I think, because it can feel longer term, maybe not have a suddenness that some of the other substances do. That doesn't necessarily always get the high profile look that it should. But there's I think it's, and I'll make sure in our follow-up information, it's 4 out of 5 deaths are alcohol attributable. And I believe it's in the 25 to 45 age range. So we did a presentation last year as part of that. So we'll confirm that. I believe that the statistic, but wow, alcohol is definitely our.
We'll plug that into when we hear about methamphetamines and other things. That would be great.
Will do.
Yeah, because this is like, we know about our, that seniors are starting to use alcohol more to relax at home, and we're like, oh yeah, I think so. And even though it's, you've just said 25 to 45, but somehow. Okay.
Thank you for allowing me to take the time about that. I'm here today to talk specifically about recovered housing. We were required last year to perform an assessment and provide a report to the legislature about recovery housing. I have a lot of wonderful information this morning to share. As part of that, we know as part of our needs assessment and our strategic plan, the recovered housing is absolutely a priority as part of that continuum and wraparound services. So we're excited to talk about that work this morning and what we're looking forward to the future. Do you want to double down also on prevention? Prevention is the surefire way to those long-term outcomes everybody's looking forward to. So I look forward to those continued conversations throughout the session.
I don't want to, I'm not going to interrupt again.
Okay.
But, you know, one of the real confounding things that happens is we all know prevention is the way to go. We know that, right? And so then we try to explain how much money it saves later on and how to measure that. Any help you can give us there would be great. But
that is one of my number one goals of this particular session, is to make it tangible and to understand how the financial impacts epic rewards on the other side. So I look forward to those conversations.
terrific. Yeah, that's it.
So I'm on the timeline slide. So I did want to give a brief history. That was part of the research that was done about recovery residences in the state of Vermont. So back in the late 80s, early 90s, you know, we had the beginnings of really peer run recovery residences. Oxford House is a type of recovery residence that's a model that's used across the country. And it's definitely very independent from state government, you know, and from Funny Circle, it's an independent space for individuals looking for a sober living environment. In the, and I apologize, this is very fine print. In the early 2000s, the legislature began providing funding for community-based recovery center organizations. So we have 12 recovery centers across the state, provide a variety of things from recovery coaching. They have programs like AA and NA and other things like that in their programs. They're out in communities everywhere, looking to engage individuals in the pursuit of recovery. We then moved into the mid 2000s when the legislature created the Vermont Recovery Network. So the Vermont Recovery Network was bringing those recovery centers together, develop policies and procedures, and sort of have a policy place and position, and give them a unified space for advocacy across the state. There is a current entity known as Recovery Partners of Vermont. Sort of there's been an evolution over time to get the current entity serving in that role. In the early 2010s, in 2011. The National Alliance for Recovery Residences was established. We refer to that as NAR. NAR helps set the stage and the definitions for different levels of recovery housing and their goals. In 2016, the Vermont Alliance for Recovery Residences was founded, and then they were then recognized as a NAR chapter. So you have a Vermont body that is currently helping us implement those in our standards and bringing those to the state of Vermont. And they're also currently working as our certification body. In 2021, this is an important note just because of resources. Phoenix House of New England did close, and with that, we lost 58 events across the state. So that
Was
was,
that because of the pandemic?
no,
No,
it was
I'm trying to
pre-pandemic. It was,
What's?
probably financial and, you know,
Right.
right things, you know, they're a large organization. But I do not believe the pandemic was they may have been an impact of that. No, that's the sole issue there. In the 2024 Act 163, which is part of the reason why I'm here today, requires recovery residence certification recommendations and the systemic assessment of recovery residences, which is some of what I'll talk about today, and including temporary landlord tenant laws. In 2025, we inventory 145 beds and 404 community recovery resources, which we'll talk about a little bit more in depth here in a second. And then you'll see in our timeline, I realize it's not 2030 yet, but we do have some hopes and dreams. In our landscape, we're looking for to increase our overall capacity to 400 beds across the state. That would be about a 250 bed increase. We're looking to for geographic equity. We do have spaces within the state of Vermont where we do not currently have beds. And in some spaces where we do have beds, we don't have enough to serve the population or the need that is there. We are also need to support specific populations, for example, individuals that are justice involved. We may be looking for programs for couples or into more individuals with dependents or individuals, believe it or not, with pets as part of the mix. And here's some of the other spaces around housing. And then looking to, a big part of this bill was ongoing monitoring, assessment, and data collection. And so be finding a way to streamline that, to try to reduce the administrative burden so programs can do the work they do, but still provide us with the data that we need and develop long-term, short and long-term outcomes that we can measure and adapt as we determine what those outcomes are. Next we'll move on to the report itself. There is a link available in this. I do obviously recommend anybody to enjoy the read. But the report itself required us to assess the four following categories. So we were asked to create a comprehensive inventory of all recovery residences in Vermont, including assessments of proximity to employment, recovery, and other community resources. We were asked to assess the current capacity, knowledge, and ability of recovery residences to inform data collection, improve outcomes for residents. We were asked to assess recovery residences' potential for future data collection capacity and assess the types of data systems that are currently in use in the state of Vermont. And a big part of that, which we were excited about, which doesn't get talked about a lot, is evaluation. We put a lot of wonderful programming out there. A lot of people are very interested, but if you don't have the data and an evaluation plan behind that, you don't know if your investment is making the impact that you're looking for. So we're excited that this particular report included those types of questions. It may be helpful. I am going to, just for the group, because I know there's some new individuals, I'm going to give you the definition of recovery housing.
That's good for all of us.
Okay. And you'll find it in the report itself. Act 163 defines a recovery residence as a shared living residence supporting persons recovering from a substance use disorder that provides tenants with peer support and assistance accessing support services and community resources. The next slide speaks to the recovery resident certification. So you are looking at what, again, we talked about NARA, which is the national level, and we've adopted that in the state of Vermont through an organization that we call VTAR. And VTAR is our current certifying body, and they certified 4 different levels of recovery housing in the state of Vermont. That level 1, Peer 1, back when I was talking about Oxford House in the original assessment, is really just, individuals come together and they're going to set up a sober living environment. Level 2, which is a large volume of our current inventory, is a managed environment, and those include house rules, and there are designated leaders in the house. So they have some internal governance. Level 3 is a supervised environment. We have a few of these in the state of Vermont, Jenna's Promise being one of those for those who are familiar with that particular space. This is a supervised environment, and they have staffing on site, and they have a large focus on life skills programming. The highest level or the next level up is a level 4, which offers clinical treatment services in-house. For the state of Vermont, Dr. Hildebrand talked a little bit about some of our treatment capacity expansion, one of those being the New Virgin's facility, which is what we call a low intensity clinically managed treatment program. Is very, very similar to level 4 in this space. So they're not necessarily interchangeable because one is driven from a treatment perspective, the other from a recovery perspective. But in the state of Vermont, we do have, though we don't have any certified as level 4s, the 3.1 that is currently happening in Virgin's and at McKee and Grace House in Rutland, Vermont through Recovery House Inc. Are serving in some respects in that manner because there's still a large component where employment is part of the mix, engaging in their community. So I wanted to put that out there just for clarification.
So if we have a patient who's coming in with acute needs or recovery needs and sort of detox, that person would start at level 4.
They would start at an even higher level than level 4.
Well,
So
okay, level.
it is, and they
Level
don't really have it.
hospital.
They have Valley Vista and Recovery House have medically managed high intensity treatment, which includes that detox piece that you're talking about. So they may go to that high intensity piece, and from that, as a result of their treatment plan, may step down to that 3.1 bed or that level 4 level after they've done that high intensity.
I was just trying to get that in place. So
Yes.
so we're moving, instead of walking up the levels, we're walking down the levels until we get to the peer support group.
So is that how it normally works?
That's how it normally works.
So they immediately go right to the,
It depends.
they don't usually start at level 1, they go to
This is housing, so this sort of comes when an individual has really developed their recovery plan and what are their needs as an individual. Each individual's journey is unique. So some
Okay.
people never touch the treatment system, go solely through the recovery space. They may find it through AA, they may find it through NA. Others may, depending on what they need, start at that highest level of clinical medically managed treatment and walk a traditional march through different levels. Sometimes people have a recurrence of use and go back up for a second and need more stabilization.
Gotcha.
So it's a very living, breathing space and meeting people where they're at in the moment in their recovery journey.
Which is one of the things that make it really complicated.
It does, yeah. Humans are complicated. Myself included. So yes, it's meant to be sort of living and breathing and move with the person as they continue to pursue their recovery goals. And our goal is to provide a comprehensive system that has every level that possibly would be needed, including that co-occurring space with mental health and physical health care, to be ready when it's needed. The next we're on to the recovery residence inventory. I just want to give you a brief inventory of the state. So we currently, per the research, and we partnered with Fletcher Group, an outside entity of part of this. So we inventoried 8 organizations across the state that have housing in 29 locations for a total of 145 beds. 26 of those locations and 100, which making up 137 beds, are VTAR certified. So certified using those national standards that we've adopted at the state level. 23 locations and 121 beds are at that NAR level 2, which has house roles and has leaders identified within the actual residence. We then have 3 locations, a totaling of 16 beds that are the VTAR certified with NAR level 3. So, speaking to some of the Genesis Promise locations in that particular space, which brings that life skills component, whether that be finance, employment, and some of those other things into the mix. We do have about a 50-50 mix of those 145 beds identified for men and for women. Within that, there is a subset that we have 20 beds available for women with children, and we have 6 beds available for men with children. And are in 8 counties, so try to get this to be available to your afterwards. Bennington, Caledonia, Chittenden, Franklin, Memorial, Rutland, Washington, and Windsor have at least 1 recovery residence or transitional housing program within them. While 6 counties, so Addison, Essex, Grand Isle, Orange, Orleans, and Wyndham currently do not. As part of that.
So just thinking about this, if you're a person who needs level 3 and you live somewhere far away, that's a problem.
It's sort of a mixed part. Some people are able, want to actually leave their community of residence or they are in active use and want to go somewhere else.
Right.
They need to remove themselves from that particular space. Others do not. So there's a sort of a mixed bag there of understanding of where, I think no matter what you need statewide geographic equity, it doesn't necessarily mean that the individuals in Brattleboro are seeking services in Brattleboro. They may be seeking them elsewhere and their movement across the state. Part of my goal is statewide access. That doesn't necessarily mean that individual's access needs to happen in their given community because it may not be the healthiest choice for them.
So we may be getting to this, but what percentage of these beds on average are filled?
They're hot commodities. So in general, this is not a space where we have a lot of vacancies. So they're heavily sought after. If anything, there's a wait list mostly in most spaces. We definitely do have some vacancies right now. We definitely have a higher need than the capacity that we currently have. I will say 40 of the beds of that 145, for example, are currently in Chittenden County. Obviously, that's a large part of the population. But that's a long way from other spaces in the states. We have obviously some spaces without them. But recovery residents growth is definitely an area that we see as a gap. It's something that we need to work towards increasing. So yes, they're not, we're not paying for a lot of empty units out there. These are heavily sought. The second part of the inventory was about a recovery residence doesn't act in isolation. It needs supports around it in its community to support the work that's happening there. So we were asked to inventory community resources across the state. So we identified 25 employment resources. Examples include hireability, which is part of the Department of Disabilities, Aging and Independent Living.
My favorite.
And Vermont JobLink. We identified 54 recovery resources, including mutual aid groups. So mutual aid groups are things like AA, Alcoholics Anonymous. And if you don't know this already, that is invented in the state of Vermont. It's one of our sensitive things. And then recovery, and we have 12 recovery centers across the state. We also identified 325 other community resources, including treatment providers, criminal justice, drug court and reintegration services, education, harm reduction, etc. I think that the most important part of all of this, again, some of the other Vermont is a leader in regards to the amount of services and things we have there to wrap around individuals seeking services. We have a wide portfolio. We don't have enough. We know there's a huge issue in those different things. As far as the things we pursued to identify, our list is deep and diverse. We are very thankful for it. I would say that one of the biggest things out there is medications for treatment or medications for opioid use disorder or medications for alcohol use disorder. We have one of the highest concentrations per 10,000 individuals in the country. For that specific space of treatment services, we have a lot of different things. This next one is a tough visual, so it's one I recommend that you take a look at when you have the PowerPoint in your hand. This is to give you a map across the state with some pop-outs that in particular areas, because when you look at the map itself, it could look like the clusters are on top and hard to read. The biggest points in this one, proximity to community resources is an important consideration when citing a recovery residence. Again, you want to have, again, we talked about transportation, we talked about, employment, access to a recovery center, access to other, life skills type of environments and education. Most counties in Vermont have higher recovery ecosystem index scores. That means the number of resources around it compared to the US average. The community resources that are available vary by county and city. The most widely available community resource, again, is medications to treat opioid use disorder. The counties with the most community resources per 10,000 residents, so who have the most per their population, are Orange, Caledonia, and Essex. And the counties with the fewest resources per 10,000 are Grand Isle, Addison, Chittenden, and Orleans.
Wow. I mean, it's the opposite of what.
It's rare that I list a
Yeah.
statistic like that.
Yes, it's interesting. Yeah, well, but people are still spread out in the more rural parts.
And it speaks to economy of scale as well. talk about resources. From a national perspective, Vermont is a leader in providing recovery ecosystem that supports individuals in their recovery and with their families. And again, Vermont has a higher index score than the country in general, and that includes other parts of our work. So everything from service programs to mental health treatment access across the country. Some of our smaller counties do have lower index scores, but across the entire service array, but we are still in general above the national average. All right, so again, a lot of the questions that were part of this report were focused on data, so we're going to shift a little bit to the data component. Recovery residences funded by the department. Again, we don't fund all of the recovery residences across the state. Currently collect and report robust outcomes data to the department. So we do still live in the land of results-based accountability. How much is somebody doing something? How well are they doing it? And trying to build entire logic models. Are individuals better off as a result of that? Based on survey feedback from the recovery organizations that participated in this, they are using data management systems specifically designed to manage their resident level data. And data collection and constant data systems are challenging for some recovery organizations. Indirect rates are a real thing. They're allowable with federal funds. There is, organizations oftentimes really focus on the programmatic piece. So some of that infrastructure part can be a real struggle within our organization. We were doing support for them to try to build that infrastructure. But funded organizations have been able to provide all departments requested data. So they've been working very hard to get that information to us. Let's see here. Again, we receive that data from them on a quarterly basis. I think the important thing to know is they are currently reporting data to us. They are also currently reporting data to VTAR as the certifying body. So we're going to be working closely with VTAR to dovetail that to try to reduce as much of the administrative burden as possible so they can focus on the work they're doing, but still give us the outcome data and the numbers served and things like that. So we're able to talk about the system at large and use VTAR to help it evolve and move forward. Again, we were actually quite pleasantly surprised that of the four responding organizations, we do have one organization that has a large, B4 has a large portion of the inventory. So we don't have, 20 vendors across the state that provide this, but the fact that they were using a data management system and are coordinating and supporting each other really is a step in the right direction. Some of the difficulties and barriers to collecting information is number one, obtaining responses from residents, incomplete data, problems importing historical data into new systems. So for example, as they evolve or if they bring on something that it's not an electronic health record, but it may feel a little bit like that. Sometimes that transition can be difficult. There's always data cleaning and analysis of any data based space. The cost itself, there's FTE time, the systems themselves, things like that. And general comfort with data collection. We have a lot of people doing a lot of great work, passionate in the field, but maybe don't have a data background or don't have that technical experience. We're trying to bring that technical assistance in those pieces to our partners. The next phase we're moving to is the recovery residents' current state findings. I don't think a lot of these will necessarily be a surprise based on our presentation and your experience with this, but just to simply go through them. First and foremost is a lack of recovery residents' capacity. The financial resources as a barrier to continued operation. The one thing I would say is, you're talking not just about services, you're talking about physical residents. Things cost different things in different counties. So the property values in portions of Shelburne may be different than Canaan, for example. So the next funding identified as a key barrier in general, lack of diversity among recovery residences with regards to the NAR levels. So again, we're talking about levels 3 and 4. We do have a significant portion of our inventory sitting in level 2. The state's current landlord-tenant law as a barrier to operations. A need for recovery residences tailored to specific populations. We've talked a little bit more. One space we're looking at is couples. Oftentimes people talk about individuals with dependents. There's also a space for partner cares. And again, what's come up a lot, especially in some of the conversations around individuals experiencing homelessness, is interest with their pets. Also do a shout out to my dog, Pets Matter. Various data collection, strengths of the state's, and again, this is sort of a mix of the strength of the state's current recovery ecosystem, transportation, travel distance, and stigma identified as barriers. The transportation is an issue across all of our service array. We're not unique in that our partners at AHS all speak to the same thing. We're a rural state without public transportation. We're thankful to Medicaid transportation and Vermont job access, but still that is a significant barrier. Many challenges being faced by the recovery ecosystem itself. Workforce is a huge issue across the board. I think that's another area of concern for us for all levels of care, and whether that be from prevention programming all the way to working as part of the recovery residents. The presentation done at the national level that I last went to was that each generation may have a theme and area where it may go to. We have about a 10-year generational gap of people with a significant decrease of people pursuing jobs in this particular field. And with that, it's not something that we can bridge, it's something we have to weather. And how do we weather that as part of the work, especially Vermont and aging states, that we don't have a population growth state, other states like North Carolina.
You brought up data a few times and it's here again on this slide. A few questions, generally barriers to data collection. I'm curious about what that looks like, because we've heard over the years how for some folks seeking help in various forms, they've had to, fill out a form over and over and over again. It actually becomes a barrier for them to receive care because of just the nature of the timelines of these forms and the, yeah. So I'm curious about that. I experienced firsthand the sort of the weaknesses in our data collection in the state this summer around working with the AOE. So I'm curious about just generally data in our state agencies. But then I'm also now this sort of new threat, which is data, being collected by the federal government to be used against people. And are there ways that you are protecting people's data? So that I know that's like a huge bucket that I just dropped on your lap. But
I think I think a couple of ways. I think that would be something that's also good for continuing conversation. I would say from a practical standpoint, I think one of the tenets of our system of care enhancement initiatives in general is reducing administrative burden. At the same time, we're working to do that. So part of this is talking about dovetailing the data collection that happens as part of grant reporting, with what VTAR is collecting as part of certification. And can we, can those become the same data set? Can there be an 80% overlap? And so there isn't, redundancy and duplicative work. I think at the same space, I don't know how the changes in Medicaid and the burden of having to apply every 6 months, trying to also free up our organizations to support individuals and helping them to continue to pursue their health insurance coverage. So I think that that was one of the things that we've been focused on for a long time. I think right now we're even more focused because we have this external piece that's going to add a significant burden, and we want to start to get out of the way to give the space for that to be able to happen. So in general, it is a key focus for us. And again, this report helps bring some of those ideas to light, especially in this particular type of programming. I don't want to say out loud that I think it's going to be a reduction because of what's coming from external sources, but it is a focus for us. In regards to protections, I don't know if I'm an expert to speak to that in particular, so I would be happy to defer to other members.
Well, yeah, we've just sent a message to the department. Maybe that's a question that we could get answered. And that'll be a more general question, I think, throughout our discussions with AHS overall. But yeah, it's a good question.
And then, so we have some report recommendations to close with. And, there's sort of couched in 4 key areas. The first being addressing barriers to expanding capacity, which we've talked a lot about. We talked about our vision, for 2030, expanding to approximately 400 beds across the state with an array of NAR levels to support the needs.
And that could begin with local zoning, couldn't it?
All sorts of things.
Anyway.
And again, that sort of covers, areas 1 and 2. So 1 is just, inventory and, number. The second is the service array and the different types of, recovery residence levels that we have out there. Amending the landlord and tenants, statute to, reduce barriers and support the health and welfare of the recovery residence space in and of itself. And then support for ongoing collection of outcome information for recovery residences. And again, doing that in a coordinated and thoughtful way. One of the biggest things I focus on is only collecting data that we use. So there's things that we're required to, depending on the funding source that may be out there. But if we're not using it, we need to do an assessment of that and stop collecting it. And things like that. So those are the 4 key areas that that are part of the report that we have already included as part of our work going forward. And we're excited to partner with our community partners, with VTR and others to make those things happen.
Thank you for that. This good. Keep going. Finish up.
I think my final thing is, we look forward to working with you, and parts of the legislature and other parts of government to continue moving this forward. I'm not in coming to any space where there's any disagreement that recovery housing is important, but it's something we need to build upon and enhance. So it was a very friendly topic for the first engagement of the legislature. That's good.
Yeah, this is good. We started working on this, I think 2 sessions ago, because this has been a 2-year report. I mean, it's a lot of work, and just want to say, very respected. I respect very much the work that you've done to complete this report. It's huge and not simple. And I'm also very happy to see that you identified the justice involved folks. I know you were at the summit in September. That was good for with the courts. And I do have a question for you. You've got these recommendations, the barriers. I mean, the barriers can go outside of our committee. So the landlord tenant statute that we dealt with in here. And then I know there are other committees, economic development committees interested in that as well. Could be GovOps interested in some of it, natural resources, if we're looking at some of the barriers that you talk about with respect to local zoning and community engagement. Addressing the gaps, then we can find a place where we want it to go, but then we know we need to know that it can get there. So there's a lot here. One of the questions that I have is not a recommendation here, and maybe it's already happening. And that is there a coordinated pathway for helping people get to where they need to get? I know because you've identified other, like needing a place for couples or people with pets or people with kids, or is there a reference base? And so I have a bill in judiciary that establishes the community justice centers as a reference base for identifying community services locally. Is there something like that for recovery residences for people or for those who are supporting people?
We are actually, as the 12 community forums that we hosted across the state, that was an identified gap in need and resource. So we are currently meeting with a variety of communities, even my own community. I'm a resident of South Burlington, and myself, from high school grad. But we are meeting with Jesse Baker in the city to talk about that. So we're working with other sister departments at the Agency of Human Services to create things and resources for judiciary that when they're looking to refer individuals into the system, how can they look at it from a co-occurring space and moving consent? So we have also identified that as an issue. And
So is it a recommendation in here?
It's a recommendation as part of our strategic plan. So it's not necessarily in this particular, but it's overarching for the entire system as part of our strategic plan.
Okay, it would be helpful to have it in this context. I'll tell you why, because now we've got a bill in there that is for justice involved people. And obviously it goes to co-occurring and other things, but it would be good to have it in here as well so that we're not, reproducing, what do you call that? When you're doing redundancy. Reinventing the wheel. Thank you, Senator. Yeah, so that's good. That was one thing that really popped up in my head as you were talking, to have that coordinated system, and it links in with judicially involved or those who are not. And it does link in with what Senator Bulick is talking about with intake for all the other things, people who don't have homes or places to live. So I'm glad you're working on that. Thank you for that. And we'll have you, as we go through the bill that relates to this, maybe we'll pick this up again and see if there's language we can put in that dovetails with the plan process that you're doing.
Sounds great.
That's good. Thank you. Thank you so much. Questions? I asked mine.
Madam Chair, one is, it sounds like you have a lot of demand. And over the last 5-7 years, is the demand starting to curb and come down, or is it continuing to go on?
So it's interesting. So I would say the demand is going up, but for me, that's a promising thing. That means people are interested in an increase in engagement and recovery, goal towards recovery. I want individuals engaging in our services. I want there to be an increase in demand because that means the number of individuals needing and not receiving could potentially be decreasing.
Good.
The additional resources that were put out there were our outreach and engagement workers as part of the opioid abatement settlement funding that came through. So we're putting individuals into our communities through our preferred provider network to meet them where they're at and try to, even get an individual to contemplate phase. They may still be in active use and working with that. So to me, currently right now where I sit, an increase in seeking access to the process.
So I think you guys are doing fantastic, unbelievable. And I met with law enforcement officials a while ago from state police and sheriffs and Newport and city PD. Some of these issues came up.
Yeah,
And
definitely.
so in some of that discussion, the law enforcement is actually trying to help get individuals there. But a surprise to me was there are some people that don't want any help.
Correct.
And I was kind of put back by that. They just don't want help. They're happy. They said that they're happy and they're in this cycle and that's what they become accustomed to and they don't want any help. Which I was quite surprised by that.
It is amazing, isn't it?
And that's where the outreach and engagement, they may not be in that moment, but at some point in time, you may get that right moment and seeking that moment and trying to find a way into the system as quickly as possible to.
So they were saying,
Yes.
they're saying that after a while they became tired of it and actually wanted help. They were sick of it, the lifestyle, or sick of the and then they did.
That was one of the biggest reasons for moving BT HealthLink to 24/7, 365 with call, chat, and anything else that constant, you could think about it at 3 o'clock in the morning, just as easily at 9 o'clock in the morning. It could be Sunday, it could be Monday. It's trying to get as many avenues as possible. We have other crisis lines across the state. Mobile crisis is certainly part of the work. You have to work with the CCBHC efforts within our designated agencies. So there's multi-pronged approaches trying to find a space which we refer to as no wrong door. However, they're willing to come in and access services. We want to make sure that we're able and there to take that up.
Thank you.
Questions? You've done it. Yeah, thank you for your work on this. And so the last slide, we will stay in touch.
That's the thing.
It'll be great. Yeah, this is very good. There's a lot here and some of it is not easy. I know the landlord tenant issue is something that comes up and there's difficulty with that and other difficulties that we have to step across, but see what we can do. And you're working with the CCRPC acronym, Chittenden County Regional Planning Commission.
Okay.
But working with the planning commissions, I think is great. I've been trying to move them into the healthcare sphere. We started with Echoes a few years ago, worked on that with them, and now with healthcare becoming so prominent, it's great to see that they're helping you.
We had wonderful participation as part of our community forums that did include legislators as well as a wide array. We did engage with over 350 Vermonters as part of that process in a 30-day gauntlet across the state that was very informative. It was reassuring because we were seeing some of the similar things. It was good to see that there was very common themes across the state because when there are common themes, you get that economy scale. It's easier to dive in and make change.
Right. And people who live at the local level have a better sense of what and where. Thank you. All right.
Thank you very
Thank
much.
you all
Yeah.
for being here. The Department of Health is a star in this.
Thank you.
Thank you very much.
So committee, I think we're where we are. I think we're a good place to stop for the day. And tomorrow we're going to get, well, this afternoon we have the governor's address on the state of the state. And then tomorrow we'll start to look at some of the background on transformation that we've been working on and you have not, but it'll bring us all to one place. Jen will be coming in on that. We're trying to get someone in from the administration to also talk about what's going on in the transformation world. Not a deep dive, but kind of a picture of where things are, what's happening with hospitals and others. And then what else are we doing tomorrow? You've got the agenda in front of you. And then we'll start to look at some of the reports that have come in. We did this report because I think it's really key to a lot of the planning that's going on in the state. And it's an important report for one of the bills that we'll be looking at. Then we're set. So we are going to wrap.